Very good evening. I'll start చేయాలి అక్కడ. A very good evening. So myself, Dr. Ramyasri. I teach obstetrics and gynecology. I hope I'm audible and visible. I hope I'm audible. Right. So I think now I'm audible and visible. So very good evening, guys. Hi, Madhubala. So today I'll be discussing, as you have requested for me to do some image-based questions as well as oncology-related questions. So I try to keep little of oncology as well as some of the images also where we can discuss. So we'll start with the session. I'll be discussing the questions and you can answer in the live chat so that we'll have a healthy discussion and it will be a good revision. And not only that, I'll try to share some simple tips. How can you remember the staging and everything, because staging is something which is very difficult and most of the time you tend to go on asking how do I remember. So here I'll try to tell you simple ways of remembering the staging, all mnemonics what we can use. Okay, so let's start with the session. So laparotomy performed in a case of ovarian tumor revealed unilateral ovarian tumor with ascites positive for malignant cells and positive pelvic lymph nodes. All other structures were free of disease. What is the stage? Stage 2C, stage 3A, stage 3B, stage 3C. I first want you to start guessing and then I'll put forward. I want you people to first start guessing. Very good evening, Madhubala, Madhura, Arul, and Srija. So I want you to remember one basic funda, that is, stage 1 will be always confined to that organ. So whichever cancer you're discussing, stage 1 will be confined to that organ. Stage 2 will go to the adjacent organs. Stage 3 will be most of the time lymph nodes, and stage 4 will be the distant meds. Now, based on my simple funda, if I answer this, it is positive pelvic lymph node. So it should be stage 3. But if you observe in the question, 3A, 3B, 3C, all are stage 3. So how are we going to answer? Okay, so I have an answer of A, I have an answer of B. Now I'll teach you the mnemonic how to remember ovarian staging. It's pretty fun. So you can remember the ovarian staging by a mnemonic, that is ABC dub mash, intra extra poda. You know, in Tamil, poda means go away, poda, right? So the mnemonic which I have here is ABC dub mash, intra extra poda. I know it's little nice. I somehow like this rhyming, you know. It might not tell you the exact staging, but it will help you in a little way to remember where what comes. ABC dub mash is stage 1. So first I'll describe ABC dub mash. ABC dub mash में A, stage 1A, confined to one ovary. 1B, B for both ovaries, confined to both ovaries. C, 1C, capsule breached, capsule involved. One or both ovaries, but capsule involved. In 1C, you again have 1C1, 1C2, 1C3, which I'm going to tell you in the form of dub mash. C1 is DU, capsule rupture during surgery. Capsule rupture during surgery. C2, B, C2 के लिए B. C2 is capsule rupture before surgery. C3, MASH, that is malignant cells in ascites positive. So that is about the stage 1A. Okay, so it is easy for you to remember. Stage 1A is ABC dub mash. 1A, one ovary involved. 1B, both ovaries involved. 1C, capsule breached. One or both ovaries, capsule breached. Now, when did capsule breach? You have C1, C2, C3. So for that, my mnemonic is dub mash. 1C1 during surgery, capsule rupture during surgery. 1C2, capsule rupture before surgery. 1C3, malignant cells in the ascites positive. Simple. So I hope this is helpful. ABC dub mash is helpful. Next, let's go to the intra, extra and poda. Okay. Stage 2 is intra. Stage 2 is intrapelvic. And I already told you, what is the most adjacent organ to the ovary? What is the most adjacent organ to the ovary? So 2A, the adjacent organ to the ovary and fallopian tube is the uterus. So 2A is uterine implants. 2B, other intrapelvic structures like vagina, broad ligament, bladder, right? So other intrapelvic organs will be in 2B. Even bladder also will come in 2B, okay? Simple. So ABC dub mash. So if you actually remember it in a rhythm, no, it is fun and nice to remember. So we have finished ABC dub mash intra. Next is extra. So stage 3 is extra pelvic. Stage 3 is extra pelvic. Extra pelvic mein you have 3A, 3B. What is first 3A? 3A is microscopic, sorry, 3A is lymph nodes. 3A1 is lymph nodes. Retroperitoneal lymph nodes. That is nothing but the pelvic and para-aortic lymph nodes. (3A2) is microscopic extrapelvic peritoneal implants. Why peritoneal implants? Because ovarian cancer has transcoelomic spread. So that's why peritoneal implants. 3B, B for big. 3B, B for big. Macroscopic extrapelvic peritoneal implants. But less than 2 centimeters. 3C, macroscopic extrapelvic peritoneal implants. More than 2 centimeters. More than 2 centimeters. And 3C also includes capsule of liver and spleen. It is so capsule of liver and spleen. So I want you to remember this very specifically. Capsule of liver and spleen are in 3C. 3C includes capsule of liver and spleen. Okay. Coming to the stage 4. PODA. 4A is bowel and bladder. Sorry, PODA. PODA. So PO is pleural effusion with positive cytology. 4A is pleural effusion with positive cytology. If you can go through it once again, no, with this mnemonic, it is easy. You'll never forget it. DA is distant metastasis. So 4B is distant mets. That is parenchyma of liver and spleen, superficial inguinal lymph nodes. All that will come under 4B. So that is about the staging of ovarian cancer. So I hope this mnemonic was helpful to you all. So it is ABC, DubMash, intra, extra, PODA. Okay. Now positive pelvic lymph nodes. So which stage was lymph nodes? It is 3A1. So I have the option of 3A here. So I'm going to go with 3A. Right? Now, Manu, you're feeling I can't remember all the stagings. I'm a little bugged off. I really don't want to remember all the stagings. I'll tell you one simple way. Remember lymph nodes with stage for everyone. And first stage will be confined to that organ itself. Second stage, adjacent organs. Third stage, lymph nodes. Fourth stage, distant mets. And that too, for ovarian cancers. For ovarian cancer, staging is 3A1. Whereas for cervical and endometrial cancer, lymph nodes are same stage. Yeah, Chakri, I'll show you. For cervical and endometrial, the lymph nodes are same stage. Who can tell me what is the lymph node staging for cervical and endometrial? For cervical and endometrial, they are 3C1 and 3C2. 3C1 is pelvic lymph node, 3C2 is para-aortic lymph nodes. Okay. I think I lost that ABC DubMash ka. I can quickly tell it, Chakri, if you want, because I think I erased that slide. I'll quickly write it for you. A, 1 ovary, capsule intact. 1B, both ovaries. 1C1, 1C2, and 1C3. For that, it is DubMash. DubMash 1C1, capsule rupture during surgery. 1C2, capsule rupture before surgery. 1C3, dub mash, malignant cells in ascites positive. So that's for the dub mash. DUB mash, malignant cells in ascites. So hope this is helpful for all of you guys. Okay, let's go to the next one. Next question now. Next. A 55-year-old female presents with PMB, postmenopausal bleeding. Biopsy shows endometrioid variety of cancer of 3 centimeters in the uterine fundus. Histology shows grade 1. MRI shows more than 50% of the myometrial involvement. Next step in the management is. I am happy even if you tell me at least which stage this belongs to. Then I'll tell you stage-wise management. You can first guess on it, then I'll speak about it. So I want you people to start answering for this. Okay, can I see any answers coming up? Or probably I should answer first and then you will come to the question. Okay, I'll explain points, then you can answer it. Okay, no problem. First and foremost, we should understand which stage this belongs to. Let's go with our basic simple funda, no? Ki if it is confined to the uterus, this is a uterine cancer and it is confined to uterus. So which stage this should be? It belongs to stage 1. So that is appropriate. So first my basic funda say we will all answer that this is stage 1, right? No. Please see here. It is endometrioid variety of cancer 3 centimeters in the uterine fundus. MRI shows more than 50% myometrial involvement. So cancer is getting confined to the myometrium itself, that is uterus itself. So this is stage 1. Lymph nodes are stage 3, but here it's only uterus is confined. So it is stage 1, but more than 50% is involved. So I'll quickly tell you how can we remember the staging of endometrial cancer. I somehow feel endometrial cancer staging is not very difficult. It is easy only. Stage 1A, stage 1 confined to uterus. In this confined to uterus only, you have 1A, 1B. 1A is less than 50% myometrial involvement. 1B is more than 50% myometrial involvement. 1A is less than 50% myometrial involvement. 1B is more than 50% myometrial involvement, right? Stage 2, adjacent organ to uterus, that is cervix. So stage 2 is cervix. Stage 3, 3A, 3B, 3C. 3A, A for A, adnexa involvement. 3B, vagina and parametrium involvement. See, B for both sides. So both sides is parametrial tissue. So vagina and parametrial involvement 3B. And adnexa involvement plus serosa involvement is 3A. 3C1, 3C2. 3C1 is pelvic lymph nodes. 3C2 is para-aortic lymph nodes. You know, actually from this 3C1, 3C2, even cervical cancer also same. Fourth stage, 4A, bowel and bladder. 4B, distant meds. Simple, so simple staging is. Again, the basic funda only you are using. Stage 1 means confined to that organ. उसमें 1A less than 50% myometrial involvement, 1B more than 50% myometrial involvement. Stage 2 means adjacent organs. What is the adjacent organ to uterus? Cervix. So stage 2, cervix. Stage 3, 3A, A for adnexa and serosa involvement. As 3B, both sides, that is vagina and parametrial involvement. 3C1, pelvic lymph node, 3C2, para-aortic lymph nodes. 4A, 4B is distant bowel and bladder and distendments. Actually, 3C1, 4A to 4B, it is same as your cervical cancer staging. Okay. So I hope this was also helpful. Easy. We have revised endometrial cancer staging. Now, management. Stage in management, for stage 1A, you again have histological grading. Grade 1, grade 2, grade 3. Stage 1A, grade 1 and grade 2. Only this stage, you have only TH plus base. Less than 2 centimeters, it's only TH plus BSO. If it is more than 2 centimeters, you can do TH plus BSO plus pelvic lymph node resection. What I want you to observe here is there is no post-op radiotherapy for stage 1A, grade 1 and grade 2. I want you to remember only that point. You know, most of your questions are based on that point only. So what I want you to imprint in your brain, stage 1A, grade 1 and grade 2, no post-op radiotherapy required, right? Now coming to the stage 1B, 1A grade 3 and 1B. You remove everything here. TH plus BSO plus pelvic and para-aortic lymph node dissection plus post-op radiotherapy also. Plus post-op radio. Okay. Now coming to the stage 2. Stage 2, it has type 2 hysterectomy. Pelvic and para-aortic lymph node dissection. Rest all same actually. Pelvic and para-aortic lymph node dissection plus post-op radiotherapy. So simple. Take a minute, sit with me, revise with me here itself so that you elevate the fear of oncology. Oncology is very simple, guys. Staging, follow that basic funda and some mnemonics which I taught you now. And treatment is so simple. Okay. So stage 1A, grade 1 and grade 2, if less than 2 centimeters. Manu, you're not able to remember so much. Remember stage 1A, grade 1, grade 2, it is only TH plus BSO plus lymph node dissection. That too only pelvic lymph node dissection. Stage 1A, grade 3 and stage 1B, it's TH plus BSO plus pelvic lymph node dissection plus para-aortic lymph node dissection plus post-op radiotherapy. Pelvic and para-aortic lymph node dissection and post-op radiotherapy is common for stage 2 also. But only thing differing is stage 1 may you're doing type 1 hysterectomy, stage 2 may you're doing type 2 hysterectomy. That's all so simple. Okay. Now coming to the stage 4, stage 3 and stage 4. Stage 3 and stage 4, you do debulking or cytoreductive surgery followed by debulking or cytoreductive means you remove everything, omentum, lymph nodes, uterus, ligaments, everything. Okay. Followed by either you give post-op radio or you can go for chemotherapy. So simple. That's all. So this is about the endometrial cancer. How do you have to remember the management of endometrial cancer? Now let's go back to the question and so that we can answer it. Okay. So in the question, which stage is this? Now you answer which stage is this? Read the question and answer. Which stage is this? Yes, which stage is this? Do you still feel it is stage 3 or is it stage 1? So this is a case of stage 1B. It's 1B. So what is the management for 1B? So the management which we do for 1B is TH plus BSO with pelvic and para-aortic lymphadenopathy followed by radiotherapy. Right? So this is about the stage 1B management. Okay. Next question. A 45-year-old woman has negative pap smear with positive endocervical curettage. Next step in the management will be colposcopy, vaginal hysterectomy, conization, Werthin cystectomy. So what should you do when you have a positive endocervical curettage? Negative pap smear but positive endocervical curettage. So a disparity in the reports as well as endocervical curettage is positive. So when endocervical curettage is positive, your colposcopy won't help. Colposcopy helps you to see only the outside surface of the cervix, but it doesn't let you see endocervix. So as she has positive endocervical curettage, I would like to go for conization. Right? Very good, very good. The answer here will be C, the conization. Right. Now coming to the what are the indications for conization? So that's also very important. So the indications of conization is you have therapeutic indications and you have diagnostic indications. Diagnostic indications is when colposcopy is unsatisfactory. Who can tell me what do I mean by colposcopy unsatisfactory? What do I mean by colposcopy unsatisfactory? Means transformation zone not visible. So diagnostic may transformation zone not visible. Limits of the lesion not visible. Limits of lesion not visible. When there is a disparity in the reports of pap smear and colposcopy, when there is a disparity of the reports of pap smear and colposcopy. So diagnostic may when transformation zone not visible, when limits of the lesion is not visible, when there is a disparity between the pap smear and colposcopy results, and when you have endocervical curettage positive or when you have adenocarcinoma in situ. Or when you have adenocarcinoma in situ. This is again a very important point. Okay. When you have, so I just have that written in the slide also. When limits of lesion not visible, when squamocolumnar junction or transformation zone not visible, when you have microinvasive cancer or adenocarcinoma in situ, and when there is a lack of correlation. Therapeutic indications are when cancer in situ in a young female, cervical cancer stage 1A1, and cervical erosion not responding to medication or cauterization. So these are therapeutic indications. Okay. So going back, you're all answered correct. Here, as it is positive endocervical curettage, but negative pap smear, as there is disparity in the report. So you're going for conization. So this is how the conization looks like, where you're cutting the cervix like a cone. Next, a case of GTN belongs to high risk if disease develops after hydatid form mole, full-term pregnancy, spontaneous abortion, ectopic pregnancy. When do you call it as high risk disease? So how much percentage of GTN can develop post-hydrated form mole? So post-hydrated form mole, we have 50% of the post-hydrated form mole, they going into GTN. Full-term pregnancy, 20% can land up in. Spontaneous abortion and ectopic pregnancy, 30% can land up in GTN. Okay, ectopic pregnancy also can land up in GTN. But which has high risk, which belongs to high risk. So when it develops after full-term pregnancy, it has bad prognosis and it comes under high risk. When it develops after full-term pregnancy, it has bad prognosis and it comes under high risk. Whereas when it develops after a hydrated form mole, it has good prognosis and it comes under low risk. As such, choriocarcinoma, GTN means choriocarcinoma mainly, right? Most common GTN is choriocarcinoma. So guys, I want you to ask one question. Is GTN has a good is a good cancer or is it a bad cancer? Is GTN a good cancer or a bad cancer? What is your opinion? Is cancers over for you all? Or am I the first one who is discussing cancers to you? Okay, remember this. Choriocarcinoma is described as it melts like snow. So with chemotherapy, it is so well responding that it will melt like snow. It resolves beautifully. Choriocarcinoma resolves beautifully and it is described as it melts like snow. Okay. It has a very good prognosis. Almost 80 to 100% survival rate is good, except the stage 3 and stage 4. It has very good prognosis on the whole as a cancer. It is described as it melts like snow with chemotherapy. Okay, I am the one who am speaking oncology. I think, okay. So probably, I think, let me speak little from a basic then, not to the other end, right? Okay. So first, let me tell you what does GTN means. So there are mainly four variants in the GTN. That is, GTD means gestational trophoblastic disease means choriocarcinoma, your molar, complete mole, partial mole, and these four. But GTN means mainly these four variants. So what is that is epithelioid trophoblastic tumor, invasive mole or chorioadenoma destruens, choriocarcinoma, placental site trophoblastic tumor. So the four variants of GTN are epithelioid trophoblastic tumor, invasive mole or chorioadenoma destruens, choriocarcinoma, and placental site trophoblastic tumor. Okay. Let me speak few things about the choriocarcinoma. Choriocarcinoma staging is very simple. Choriocarcinoma staging is very simple. Choriocarcinoma में, so guys, you will, whenever you are going to learn the cancers, you're going to have a better time. Matlab, you know, it will be easy for you because you have learned now ovarian cancer staging. So I think you will not forget ABC, DubMash, intra, extra, PODA, right? Apart from that, you will also be able to answer endometrial cancer staging as well as management. And we are also learning GTN, just this gestational trophoblastic neoplasia. So this staging also I'll make it very simple for you. Stage 1 means confined to uterus. Stage 2, adjacent, that is vagina and paraurethral nodules. Stage 3 is lungs. And stage 4. Stage 4 is brain and liver. Simple, so simple, right? So stage 1 is uterus, stage 2 is vagina, stage 3 is lungs, stage 4 is brain and liver. Okay. So the ideal treatment for metastatic choriocarcinoma in lungs in a young woman is chemotherapy, surgery with radiation, surgery, wait and watch. See, actually for your choriocarcinoma and all, no, they won't, most of the time, all oncology management, they'll just ask what is the modality. They won't ask you precisely type 1 hysterectomy or type 2 hysterectomy. They won't ask you so precise. They'll just ask you whether it is a chemotherapy or whether it is a surgery. That's all they'll be asking you. Okay. So ideal treatment of metastatic choriocarcinoma in lungs in a young woman is it chemotherapy or surgery with radiation or surgery or wait and watch? So I'll tell you, in lungs, when we have choriocarcinoma, it will look like cannonball appearance. So this is the image which can be asked as an image-based question. You know, this is called cannonball appearance. Okay. Let's see the management also. Stage 1, low risk. You have WHO scoring system. So stage 1, low risk, it is single agent chemotherapy. What is a chemotherapy drug which we use for choriocarcinoma? It is the methotrexate. Methotrexate. Stage 1 FIGO, high risk. It is combination chemo plus hysterectomy. Actually, from here, all stages, you can remember it as combination chemo plus hysterectomy. If you want to know precise, you can go further. Otherwise, all you can remember it as combination chemo plus hysterectomy. Okay. So stage 1 FIGO with high risk, it is combination of chemo plus hysterectomy if family completed. Stage 2 and stage 3 FIGO, low risk, is also same. Combination chemo plus hysterectomy, family completed. Whereas stage 2 and stage 3 FIGO with high risk WHO, it is combination chemo plus hysterectomy irrespective. Stage 4, again it is combination chemo plus hysterectomy plus additional metastatic resection of the hepatic and craniotomy and some radiotherapy for brain and liver. So what did you understand? I'll tell you simple funda. Everywhere you have to learn this simplifying the things. Your concept should be strong, but you don't require to by heart every single point. You have to make everything simpler, you know, so that when you are going back and reproducing it, you should be able to reproduce it very well, right? So my way of remembering this table is stage 1 FIGO low risk is single agent chemotherapy, whereas all other stages, stage 1 high risk to stage 4, I'm going to remember it as combination chemo plus hysterectomy. Now somewhere I have to use my brain that family is completed or family not completed. Hysterectomy to be done or not done depends on whether they are high risk or low risk, but believe me, they have not asked you so much depth. Okay, simple, clear. Stage 1 FIGO low risk single agent chemotherapy. Stage 1 FIGO high risk, or stage 2 and stage in all other stages, you have to remember it is combination chemo plus hysterectomy. I've been going on telling combination chemo, combination chemo. What is this combination chemo? So the combination chemotherapy which we are going to give here is Emaco regimen. So what is this Emaco regimen? That is etoposide, methotrexate, actinomycin D, cyclophosphamide, oncovin. Oncovin is also called as vincristine. Etoposide, methotrexate, actinomycin D, cyclophosphamide vincristine. That is the Emaco regimen. It's actually called as Backshaw regimen. The mnemonic which it comes is Emaco. It's called Backshaw regimen. That finishes choriocarcinoma. Over. So those were some of the cancers which I discussed, not all. I didn't discuss much about the cervical cancer. So probably if I get a chance again to come back and interact with you all, I'll share some more mnemonics even in cervical cancer. Yes, I do have many mnemonics and the easy way of remembering along with the clinical questions. You always should get a full package, right? Don't worry. So as and whenever I get chance to speak to you all back, I'll definitely come back with those all things, other cancers also to cover back. Okay, one of the simplest and favorite question of the examiners. A woman presents with fluctuant, non-tender swelling at the introitus. The best treatment is. So first you have to tell me what is this image. What is this image? This is called as Bartholin cyst. As it is non-tender, it is cyst. Okay, so this is Bartholin cyst. And what is a management of Bartholin cyst? Now you should ask me, how did you identify this as Bartholin cyst? Because Bartholin duct is present at the junction of upper 2/3 and lower 1/3. So this is present in the junction of upper 2/3 and lower 1/3 and it is enlarged. So it is usually present in the posterolateral wall of the vagina at introitus. And whenever that Bartholin duct is blocked, it will result in Bartholin cyst, which is fluctuant non-tender swelling at the introitus. When this gets infected, it forms Bartholin abscess. Bartholin abscess is painful and tender. And the most common organism causing Bartholin abscess is E. coli more than gonococci. It is E. coli more than gonococci. Okay. Excellent, Madhubala. So the management here is marsupialization. Marsupialization. So what is this marsupialization? So you make an elliptical incision on the on the Bartholin cyst. You drain out all the products, all the cyst content, and you leave the cyst open. You're not going to suture it back. You're going to leave it open so that the drainages won't pent up and they continuously drain and go away. So that is the marsupialization. What happens if you close that? Some amount of secretions can still form and they get again enclosed and there will be a recurrence. So you keep an electrical incision and you suture to the walls. You don't close it. Okay, that's the marsupialization. Next, a 48-year-old female suffering from severe menorrhagia, that is heavy menstrual bleeding, underwent hysterectomy. She wishes to take hormone replacement therapy. Physical examination and breast are normal, but X-ray shows osteoporosis. The treatment of choice is progesterone, estrogen and progesterone, estrogen, none. So what will be the answer for this question? So here, she wants to undergo she wants to take hormone replacement therapy, right? But she underwent hysterectomy. So she is trying to take hormone replacement therapy for osteoporosis, right? So you can give hormone replacement therapy for osteoporosis, for urogenital atrophy, for hot flushes. but you don't give hormone replacement therapy for prevention of coronary artery diseases. That's also an important MCQ. So, what do we give in hormone replacement therapy? In hormone replacement therapy, we normally give estrogen and progesterone. Now, why? The name itself tells hormone replacement therapy. So in the old age women, all the problem is because of the hero hormone for the woman is lost. So the heroine hormone, not hero, heroine hormone for the woman is lost. And the heroine hormone for the woman is estrogen. And as the estrogen is gone, she'll face all these difficulties of osteoporosis, hot flashes, uh, mood swings, urogenital atrophy, wrinkling of the skin. Now, for this, I have to replace the estrogen back. So, I'm going to call this as hormone replacement therapy. But what will happen if I give only estrogen? Estrogen is agonist to the uterus. So what will happen? Estrogen will lead to proliferation of the endometrium and lead to endometrial cancer. So when they have uterus, I have to give along with estrogen progesterone, and progesterone is like a dominant husband. Remember, this point in gynec is very important. Estrogen causes proliferation of endometrium, whereas progesterone leads to atrophy of the endometrium, or progesterone is anti-mitotic, or progesterone is anti to receptors of estrogen. Progesterone is like a dominant husband which is telling estrogen chup. Right? I know it's little kind of rude for progesterone, but yes, progesterone is not there, then this estrogen would have grown endometrium excess, right? So we require progesterone to prevent endometrial cancer, right? But so if uterus is present in HRT, I agree with you, you give both estrogen and progesterone. But as uterus is knocked out here, there's no uterus here. So when there is no uterus, do you want to give only estrogen or do you want to give progesterone also? They are not sati. We don't require progesterone anymore because there is no uterus itself. So when there is no uterus in HRT, you give only estrogen. You give only estrogen, right? So now I see you people answering. Very good, Shankar Deepu. Correct. You've answered it correct. It is both. It's only estrogen which is required here. I hope now all of you understood why it is only estrogen, because you have knocked out the uterus. That's why you're going to give only estrogen here. Okay. We don't require to give progesterone. Next question. A 36-year-old female with 2 alive children complains of dysmenorrhea and dyspareunia. TVS shows a thin-walled cyst, 4 into 5 centimeters, with echogenic fluid and no solid areas in the right ovary. She doesn't wish to conceive. What is the first line management? And this is the image. This is the cyst. So that's the question. And this is the cyst. Can anybody answer what is the diagnosis here? So let's first describe the ovarian cyst. So this is homogeneous cyst, and this is called as unilocular, homogeneous unilocular, and it is echogenic, and this is called as ground glass appearance. Ground glass appearance. It has ground glass appearance. Okay. So it has 2 alive children, complaints of dysmenorrhea and dyspareunia. Another thing here is ground glass appearance, echogenic fluid, and apart from that, dysmenorrhea and dyspareunia. Dysmenorrhea, dyspareunia, and ground glass appearance fluid is a combination for endometriosis. You know, last exam we got 2 questions from endometriosis, and one of the questions which they asked was it actually came little more simpler than this question, to be frank. So one question was, what is the most common symptom of endometriosis? The triad of symptoms of endometriosis, you can remember it as DID, Dance India Dance, dysmenorrhea, and the dysmenorrhea is the most common symptom, that is pain abdomen. And the dysmenorrhea which we have here is secondary dysmenorrhea or congestive dysmenorrhea or a triple dysmenorrhea. That is, she's going to have pain throughout the cycle. She's going to have the pain throughout the cycle. Okay, so they have dysmenorrhea, dyspareunia, and infertility. So they are going to have dysmenorrhea, dyspareunia, infertility. Okay. So I see an answer of A, but there is a twist. Let's come to the twist. So this is a chocolate cyst which she is having. And please see here one very important point. She does not wish to conceive. She doesn't wish to conceive. As she doesn't wish to conceive, you don't require to go for cystectomy. The first line drug for endometriosis or chocolate cyst is GnRH analogs. The first line drug is GnRH analogs. Okay. And sorry, the first line drug is progesterone, whereas the drug of choice is GnRH analogs. Drug of choice is GnRH analogs. Here, if she wishes to conceive, then I would have come with your answer. Then the answer would have been laparoscopic cystectomy. But as she does not wish to conceive, you have to go with the first line management, that is progesterone. And what is the progesterone which you have here? Treat with injection DMPA. So the answer here is D, treat with injection DMPA. Whereas the drug of choice is GnRH analogs. The drug of choice is GnRH analogs. Okay. So this is the image of ground glass appearance. That's also very, very important. Next question. Lady with infertility with bilateral tubal block at cornu. Best method of management is laparoscopy and hysteroscopy, hydrotubation, IVF, tuboplasty. Whenever you have severe tubal block, always remember the management. The best management is IVF. So it's severe tubal block. So here she has bilateral tubal block. So the best management is IVF. There's many times this question repeated to you in exam in a different way. That is, lady with infertility with bilateral tubal block at cornu on HSG. What is your next step? This is one more question which they ask you from this topic. What is the next step? Lady with infertility with bilateral tubal block at cornu on HSG. What is the next step? So on HSG, if you have bilateral tubal block, see, to check for the tubal patency in infertility, the first line investigation is HSG. So when you push the dye, you will be able to see inside the uterus as well as you'll be able to see the tubes. So on HSG, the first line is for checking the tubal patency, the first line is HSG, right? But only disadvantage with HSG is it has false positive tubal block. So as soon as the dye comes up, the tubes undergo sudden spasm. So that sudden spasm will lead to closure of the tubes, will lead to closure of the tubes. So what is the next step which you have to do when you have a bilateral tubal block at cornu on the HSG? You have to confirm whether it is a real tubal block. And how do you confirm whether it is a real tubal block? You're going to confirm it by laparoscopy and hysteroscopy. You're going to confirm it by laparoscopy and hysteroscopy. Okay? Those are the two questions, two possible questions which they can ask you. I just wanted to tell you one more question. So when do you do HSG? When should you do HSG? HSG is done on day 2 to day 3, day 8 to day 10, day 14 to day 20 at any time. So I'll show you the Leach Wilkinson's cannula. Just give me a minute. I have the Leach Wilkinson's cannula. This is the cannula which you put inside the cervix and then you push the dye. When you push the dye, you're going to see the dye delineating the uterine cavity, fallopian tube, and dye coming out like this images. So cervix it's going to the uterus, it will come out through fallopian tube. So here they have used two Leach Wilkinsons because it's a uterine anomaly. So that is the HSG picture. Now I want you to answer on which day you're supposed to do HSG. Is it day 2 to day 3, day 8 to day 10, or day 14 to day 20, or at any time? What happens if you do HSG at any time? If I do HSG on before 5th day, Mano I have done on day 2 to day 3, what will happen? She's menstruating. So menstrual blood will also go back. So I'm causing iatrogenic endometriosis, right? And if I do HSG on day 14 to day 20, she's implanted. I'm going to disturb that pregnancy. So on which day you're supposed to do HSG? It is day 8 to day 10. It's the day 8 to day 10. Excellent, Chakri. Very good. The contraception method shown below in the image is made of. So what is this contraceptive method which you are seeing in the image and what is it made up of? So what is this which you are seeing in the image? So this is hysteroscopic tubal ligation. This is hysteroscopic tubal ligation. Okay. And in this hysteroscopic tubal ligation, we also call it as Essure. Essure. We call it as Essure. It's actually developed in the France. So what you do is through a hysteroscope that is from below, you pass out this small micro coil. This will go and sit in the fallopian tubes. And this coil will slowly undergo fibrosis and block the tube completely. And it will block the tube completely. Okay. So what is this coil? It is the Essure coil. What is this made up of? This is made up of nickel and titanium steel alloy. This is made up of nickel, titanium, and steel alloy. So this is the Essure. Very good, VS. This is called Essure. It is made up of nickel and titanium steel alloy. So it takes 3 months to undergo complete fibrosis of the fallopian tube and block the fallopian tube. So what do you do in these 3 months? So in these 3 months, you have to what do? You have to give additional contraception. And is it a permanent or temporary method of sterilization? This is a permanent method of sterilization. This is a permanent method of sterilization, right? And can we reverse this? Manu, if I pull out the coils also, will we get the fallopian tubes back? It is irreversible. It's completely irreversible. Okay, and it's a permanent method of sterilization. So that is called as Essure, and the coil which is you're seeing is made up of nickel and titanium steel alloy. So that was for today. Probably we can do one more. Okay, I think we'll do one last and then end for today. A 24-year-old woman comes to the genitourinary medicine clinic complaining of small multiple group of painful vulval ulcers. On examination, the base of the ulcer was erythematous and inguinal lymph nodes are painful. What is the most likely diagnosis? Chancroid, granuloma inguinale, herpes simplex virus, lymphogranuloma venereum. So this is about the ulcers, This last question I'll tell you and I'll stop. So please remember there are two painful ulcers. The two painful ulcers, you can remember them as high coat, herpes and chancroid. Herpes simplex and chancroid are painful ulcers. These are the two painful ulcers. Herpes simplex is caused by HSV2. So this have multiple small ulcers, and the base of the ulcer is erythematous. Whereas chancroid is caused by Haemophilus ducreyi. This also causes multiple ulcers with sharply demarcated edges, and the base of this Haemophilus ducreyi will be covered by dirty grayish exudate. So it causes foul smelling discharge also. Dirty grayish exudate it will have. Whereas HSV, it will have erythematous. So that is the reason why I'm going here with herpes simplex virus, not chancroid. Okay. Both can have lymph nodes which are painful. The management or drug of choice for herpes simplex is tab acyclovir, whereas the management of chancroid is injection ceftriaxone. Right? So the answer here is herpes simplex virus. Mainly HSV2 causes the ulcers. HSV1 above umbilicus infections. HSV2 causes below umbilical infections, right? So that's for today's questions. And thank you guys. I hope you enjoyed my sessions and it was helpful for you. Whatever sessions I've done. And if you have missed any of the previous sessions, I've also done one FMG recall session. So go through that. And every session I've done a good set of clinical based MCQs. So take the advantage, go through them. They are definitely beneficial. And as they are free class, like, YouTube, you have the access unlimited. You can watch them. So do share to your friends also so that they can also get benefit of the classes. And any doubts or anything you're not able to remember and you want me to give a easy way of remembering it, always welcome to ask me. I am Dr. Ramya Sri. ID is Obstetrics and Gynaecology. You can search my name on the Facebook or a messenger to find out, to ask me any queries pertaining to obstetrics and gynecology subject. So thank you guys. All the best. Keep studying. 2 months. Just go on reading like it's like a mission. So just go for it and be strong, be positive. Never think of anything negative. I don't remember, I can remember. No, you remember, you are going to get 200. That's all. 100%. Let's not have a second or third thought about this. Okay. Thank you.